What's going on, Warriors and Battle Buddies? This is Nick Krantz, and you're listening to Drew and Terry Niemann on A Battle Within.
Here we go with episode number 135. Terry, the inspiration for the program, will join us shortly, along with today's special guest, Dr. Patrick Quaid. The conversation that we offer today is one of the most important ones yet in my view. Dr. Quaid is a leading authority in vision as it relates to traumatic brain injuries and children with learning difficulties. He has gotten into this line of work based on his own experiences with his own TBI. The through line of all his work/career has been his studying of how the brain processes visual information. Dr. Quaid has lectured over 750 times worldwide, has been an author of many research studies and books on the topic, and is pretty adamant that the tag mild needs to go away as it relates to head traumas. In addition, we discuss some alarming statistics around traumatic brain injuries that need to get out into the forefront of society. One of significance is the fact that 50% of children with learning disabilities, or difficulties as the doctor likes to call them, are victims of a traumatic brain injury and actually need help with their vision. If they did, their difficulties would go away. Aside from listening into the conversation, you must click through all the resources that are offered in the show notes as well. There is a ton of additional information available via links, and just as importantly, the studies we discuss are there and are downloadable as well. Please take the time to listen to the entire episode, even if it's in chunks, and be sure to share with everyone you know in this world, including your medical professionals. We will get to this important conversation shortly, but first, folks, don't forget, leave us a rating and review at Apple Podcasts if you haven't done so already. And if you're getting any kind of value out of the program, we would appreciate the support at buymeacoffee.com/abattlewithin. Supporting the show there makes you eligible for some special benefits, including some one-on-one time with Terry and myself, and some goodies that will get off to you. For those who have already donated, we thank you. It truly does make a difference. And today we must give out a shout out to Marianne, who made a very generous donation this week to the platform. We appreciate you, Marianne. Thank you. Okay, folks, here we go. Let's get after it with Dr. Quaid and Terry.
A Battle Within is about Terry and Drew's life experiences and those of their guests living with and healing from traumatic brain injuries, with an emphasis on Post Concussion Syndrome. The conversations are real, raw, and uncensored from both the warrior and caregiver perspectives. From time to time, medical professionals are offered as well. This platform is intended to be a useful way to create awareness around the invisible injury and to help those in the battle. Whether you are the warrior or the battle buddy, the stories and resources offered here take aim at helping you in your own journey. Join us each week for meaningful conversations that truly do matter for those affected. Let's battle together.
Well, hello, Doctor. So glad to have you join us today. I got to be honest with you, folks, and Terry, I've been looking forward to this conversation here with Dr. Patrick Quaid for quite some time. And Terry, I know normally you don't know much about the guests that are coming on the program, but right. You know a little bit about this particular individual because he actually consulted with Dr. Rochester a little bit on your case, which We'll talk about. All right?
Yeah, so you were nice enough to let me know. Hi, Dr. Quaid. Thank you for being here.
Hi. It's a pleasure, and thank you, folks, for doing what you do with this podcast. I think it's really important, so thank you for doing that.
You're welcome.
To give you a little bit of the lowdown, a little bit of the background here on Dr. Quaid, and for the listeners out there, he's originally from the Republic of Ireland, Terry, but these days he spends his time above the border up there in Canada, where he has his own practice called View Cubed, and he also teaches a medical school up there.
In an optometry school at the University of Waterloo, but I'm still an adjunct professor at the University of Waterloo, but I spend the vast majority of my time in my clinics. One's in Toronto, one's in Guelph here in South Ontario, but it's so the View Cubed, the VU stands for Vision Unlocked, and the E Cubed is Engage, Enhance, and Empower. That's our mantra in our clinic when we treat our patients. So it's, maybe I'm a crazy academic, I've done my PhD, but I'm actually happier in the clinic, in the trenches with patients. So it's actually a lot more fun.
Wow, that's awesome. That's
the
awesome.
Hands-on.
Yes. the good doctor here, Terry, he mainly deals with treatment for visual dysfunction, both in concussion-related cases, as well as children that might be having learning difficulties.
Which could be coming from the vision.
And like I said a little bit earlier, he consulted a little bit with Dr. Rochester on your own particular case. So I think it's pretty evident here in our early conversation so far here with the doctor that he's got a pretty good passion for visual rehabilitation. And my educated guess is that this probably grew out of the fact that he himself experienced a traumatic brain injury when he was 8 years old. And I could go on and have this long introduction about what he's done and what he's all about, but I don't really want to get into that because then we'll waste time just in the introduction, and I want to get into the meat and potatoes of the conversation, all right?
Okay.
But I did pick out a few things that I think is worth talking about. Now, I've watched some of the lectures that the doctor has given, and it was crystal clear in some of the lectures that I watched that he's very passionate about what he's doing. And he believes that the medical community on the whole needs to get a little bit of a better understanding on this front. And he's interested in delving into that a little bit as well.
On the front of the vision component or concussions or both?
Both.
Okay.
Both, yes. Obviously, the meat of our discussion is going to be around his work related to concussion, right? And as it relates to vision, okay? He has written and been involved in writing multiple books on the subjects as well. And there'll be links in the show notes to all the books and some of the talks that he's given, that kind of thing. So are you ready to go, Terry?
I'm ready.
All right. Anything we missed, Doctor, that's worth mentioning in the introduction?
No, I think that's cool. I always get embarrassed when I'm doing lectures and somebody spends 20 minutes reading a bio, and I just think you must be talking about somebody else. Let's get on with the lecture. You know?
Right. I don't want to get into it too much. As I mentioned in the introduction, you are obviously a warrior yourself, which is what we call the folks around here that have experienced a traumatic brain injury. Can you tell us a little bit, start the conversation there and what happened with you as a boy and, your effort to get better and all those kinds of things to really lay the foundation here?
Yeah, sure. I'd be happy to. And I think it's kind of what got me started into this career. So I think it's quite appropriate. And I think when I was about 8 years old, pre-8, I had no developmental issues. I wasn't born preemie or low birth weight because those are also risk factors for eye teaming issues that a lot of people are not aware of. But when I was about 8, I was actually outside. I was involved in a motor vehicle accident, and I was knocked out of commission significantly. I had a speech issue. I had a speech impediment. I also saw double. So when I tried to read, I would tilt my head off to one side. Now I realized to use my nose to block one eye to stop me from seeing double. So I was pretty much a mess for about 2.5 years. My dad was in the military. My mom was a nurse. It's one of those things where, you get involved in MVA, you look like you're fine. The docs check you out. Imaging's all clear, all the usual story. We make this fatal mistake that if the MRI or the CT is clear, everything's fine, which couldn't be further from the truth. Right. And I think what's interesting is everybody picked up on the speech issue first because they could hear my stammer. And it was kind of interesting because I had no speech impediments prior. And I still remember, being in early grade school and, you're sitting there and the teacher's moving along the kids, getting each kid to read out loud. And it's getting closer and closer to you. And you feel like you're sitting in a trench with bombshells going off. And it's just like your blood pressure goes up. You're like, oh my God. And then eventually, the teacher gets to you. And when I was looking at the page, everything was double. Everything was coming in and out of focus. I'd managed to hold it together enough to read one paragraph in my head. So I practiced it in my head. And then when the teacher got to me, I read it out. And I actually did a pretty good job. So the teacher was like, oh, do you want to do the next one? And I just fell apart. So it was interesting because when my dad realized there was a problem, I was probably one of the most passive kids you could ever meet. But when I was going through that probably for about a year at that point, so I was probably about 9, kids can be cruel. And when I was seeing double and having trouble with reading, when the teacher was getting me to read out loud one day, one of the kids behind me was kind of making fun of me behind my back. He was imitating sounds of me reading, and something in me snapped. I turned around and I smacked him. and my dad got a phone call, and as soon as the day he got that phone call, he's like, "There's something significantly wrong. That's not my kid." So I think that's when he kind of got the wake up call. We ended up going through, cutting a long story short, the speech issue was treated. I mean, the speech pathologist did a great job with me, but the vision issue was missed. And I think we went through probably about 15 or 16 optometrists and ophthalmologists before finally my dad took me to an optometrist who actually had an army background. And he ended up, I'll never forget, I'm sitting in the chair And the doc elevates me up to eye level, which was a really cool move. Like in retrospect, you don't want to look down at this, you're this big towering doctor staring down at this kid. So he elevates me eye level, and he picks up a little rod, and, he puts it in front of me, and he says, I want you to look at this little ball. And I just said, which one? And he stopped and he goes, how many balls do you see? And I said, 2. And he turns around to my dad and he goes, and you're wondering why you can't read. I was literally in the chair 3 minutes, and this guy had already done miles more than the rest of the doctors.
Wow.
The downside was when I would look at the eye chart, it was 20/20 in one eye, 20/20 in the other eye, he's good to go. So 20/20, all it means is I can see size 20 font at 20 feet. It's one of 17 visual skills. I mean, you need the other 16 to read. And actually, the 20/20 on the eye chart is the least predictive of function. So the one thing that's actually the most, and it's not completely useless, but it's probably the least useful metric of all of them, is the thing that we check the most. So the routine eye exam really didn't cut it. And that is really not a jab at the routine eye exam. The routine eye exam is perfectly fine for the routine person, but if you've had a concussion, a brain injury, or especially if you have a learning issue, or what we call an IEP, or individualized educational plan, the paper that we published in a medical journal in 2013, in a medical ophthalmology journal, we took 50 IEP cases and 50 controls, and we showed that in the control group that were reading well, the incidence of eye teaming issues was maybe about 6%. In the control group, in the IEP group, it was anywhere between 82 to 84%, depending on the metric that you use. So yet both groups on average saw 20/20 and would pass an average eye exam. So from my perspective, when we published that paper, I thought, that's really where my passion came from. And I'm not going to say that optometrist in Ireland completely treated me, but he treated me well enough that I could function. And I think I started getting that bug for eye care. And I really, at that time, I said, I want to be an eye doctor. That was cool. So I ended up going through high school. This is in the Republic of Ireland, where we St. Clement's College in Limerick, where some of the teachers are teachers, but some of them are teachers, but they're also monks. It's run by the Christian Brothers School. So anyone who hears that name usually will cringe. But they were actually really good teachers, right? I mean, they were strict as heck, but they were good teachers. And what I remember is going through high school, I ended up having another more minor concussion playing basketball when I was about 16. And I remember vividly, I'm the youngest of 3. Myself and my brother slept in bunk beds. And I remember getting out of the bottom bed and stepping on the floor. This is about a week after I got the knock playing basketball. And it didn't seem like a big deal. But I got out of the bed and I literally just crumpled on the floor. And I thought, and I looked at it, was almost like my legs weren't working. It was the most bizarre experience. And my brother got out of the top bunk, and of course he's teasing me. He's about 2 years older than me. He's like, you just don't want to go to school. And I'm sitting there going, no, I'm serious. I literally can't move right now. And it went away after a couple of hours, but that was a really scary experience. And the vision issues kind of came back a little bit, but not enough to mess me up. So long story short, I ended up going through the rest of high school. I did well enough to get into optometry school. I was one of these kids where, I still got A's, but I had to put in probably 3 to 4 times the amount of work compared to everybody else. So I was getting it, but I was burning a lot of gas doing it. So I finished high school, ended up doing my undergrad in Dublin, did my optometry school in the UK. And I was actually very disappointed with optometry school, to be quite honest, because I got through optometry school. They taught, they did a great job of teaching how to flip the lenses and prescribe the glasses and check for eye disease and things like that, prescribe antibiotics and steroids and all the doctory stuff. But they didn't really teach any of the functional rehabilitation stuff. And the stuff they did teach was very, very basic. So I decided to, I was lucky enough that optometry school, I didn't end up in as much debt as everybody else, because in England at the time, in the EU, they had an agreement where the tuition wasn't actually that high. If I'd have done optometry in the US, I'd probably still be paying off the debts now.
Probably.
So I finished optometry school in England, tried to get my first job out of optometry school, and I really didn't want to work in the private sector doing regular eye exams. I wanted to do something more connected to what I was passionate about. And I ended up getting a job in Moorfields Eye Hospital in London. I worked for a bit in Bradford Royal Infirmary in the middle of Bradford. Bradford's a great city, but it's kind of like the Bronx of the UK. It's a pretty rough area. If you want to learn pathology, you'll learn it very quickly there. And it's interesting because I met a lot of really good docs there from a TBI standpoint. And what was interesting is when I went to Moorfields and I asked them, any chance of a job basically between Bradford Royal Infirmary and Moorfields. And Bradford said to me, the director was actually Irish, so I really lucked out. And he said, we have a job that we can give you all the overtime you want. I was single at the time, wasn't married, didn't have kids. There's no way I could do that now. But he basically said, I'll give you all the overtime you want. And I said, well, what's the job? And he said, well, it's doing eye examinations on jail inmates. I thought, ooh, okay. But it was all male jails And it was including some of the maximum security areas.
Oh, wow.
So it was interesting because from doing eye exams on these folks, it was heart-wrenching. I mean, the amount of traumatic brain injury, concussions that I saw in there was insane. It was absolutely insane. You go back in their history, most of them didn't finish high school. They had several knocks. They came from broken families. There was like, these kids didn't stand a chance. So I ended up finishing that stint for a couple of years, paid off all my student loans in about 3 years, which I thought was cool. And then I thought, okay, if I start to work a regular job, I'm never going to go back to being a poor student. So I thought it's either now or never. I either do like a master's or a PhD, and I really delve into what I'm interested in. So I put some feelers out there, and this is a shout out to Professor Flanagan at the University of Waterloo. He's now actually the Dean of Optometry in Berkeley. He was my supervisor for my PhD. I'll never forget day one to me. He said, Patrick, remember the mind is like a parachute. It's something of use when open. And I thought, ooh, I like this guy. He's an out of the box thinker. So I basically studied how the brain processes visual information. And when people say, what was your PhD in? What was your piled high and deep in? I say, well, it was in psychophysics. Sounds really boring. But if I say it was in visual illusions, it sounds cool. So it's like, I like to tell people, I studied how illusions trick the brain and what it teaches you about how the brain works. And I've actually applied a lot of that work in my rehabilitation. So it's been, publishing papers and interacting with people like Dr. Singman, Eric Singman, who's an MD, PhD out of Johns Hopkins. He's the chief of neuro-ophthalmology there. So shout out to him. Him and I co-authored a couple of book chapters in a medical textbook. And he's a shining light in neuro-ophthalmology, because a lot of the MDs, and this is, I don't knock them, they're good folks. When it comes to acute care and pathology, they're the people you want to go to. If you have a brain bleed, a subdural heme, they are the people. But if, the MRI is clear, the neuroimaging is clear, there's no disease or pathology, but the patient has light sensitivity, eye tracking issues, they can handle visually busy areas. And I'm sure Eric would agree with me on this, is that, the MDs are not, they're acute care, they're not rehabilitation most of the time. Unless you're a sports MD, it might be different, but the vast majority of MDs are diagnostic. So it's really incumbent that they're aware of the patient sitting in their chair that has significant symptomatology. I mean, these patients have Post Concussion Syndrome patients have a 3 times higher rate of suicide compared to the general population. There was actually a CMAJ, a Canadian Medical Association journal paper published. And this, I'll tie it back to Ireland and my story coming from Ireland, but this was published in 2016 in the CMAJ. And they showed that Post Concussion Syndrome patients have a 3 times higher rate of suicide. And the tragic statistic is 50% of the patients who actually did it had a documented visit with their physician within the last week of life. That's an absolutely depressing statistic. So when people say, when we say we're handling this area well, we're not. As healthcare professions, we're not.
I would have to agree, because 2 things really stood out. I think support what you just said there. Special education students, and I was a special educator, and I never would have identified vision. It was a learning disability. It was emotional support, all this other stuff. There were, if maybe we had looked at that piece, and then in the prisons. Yep.
And actually, it's really interesting that when we started to look at our own clinics, we started to look at the pediatric population, who are all mostly, our patient groups can be broken into 2 groups. There's the adult concussions, there's the pediatric learning difficulty cases. I don't like to use the term learning disability because it sounds permanent, and it tends to put these kids down when they hear that term. And what's interesting is at least half of our pediatric learning difficulty cases had no developmental risk factors. So they weren't preemie, they weren't low birth weight, but they did have at least one significant potential concussive event. So I sit back and I go, how many of these kids are actually not learning difficulties, but undiagnosed and untreated pediatric concussions? And from the numbers that we looked at, we reckon in our clinic, it's at least half of our pediatric learning difficulty cases.
Wow.
That's crazy. And that needs to get out there more. Really does.
If I'm hearing you correctly, Terry, if you were still teaching, you'd be all over this at this point.
Yeah, it makes me want to go in and speak on it too.
You tell them the business here, that they're missing the boat on this one?
Yeah, maybe some of their in-services or something.
Because as well as with the children or the prison population that the doctor worked with, you and I have also done some episodes on TBIs in the homeless population too. So I'm sure it's very similar on that front as well, right? Yeah. I like the stats. This doctor here, Terry, he's big into stats, and I like stats too. So I'm gonna run a few here and see if we can get the doctor to give us some input here, right?
Okay.
Sure.
Now, you already spoke to half the learning difficulty kids. half of them have undiagnosed pediatric concussions. You already spoke to that. But you also speak to the fact that 40% of the brain is actually visual machinery. Wow. Can you talk to that a little bit? What exactly that means?
Yeah. And I would say there was a really, one of these classic papers, and my poor wife, she says, you're like a walking PubMed. You can quote these things off the top of your head. And I think I just talk about it too much. So there's a Fellman and Van Essen paper from 1991, which was done on macaque monkeys, which is the most similar visual system to ours. And they found that it was actually at least 40% was visual machinery in the brain. So when I think about that number, there's something called ganglion cells, which are neuronal connections between a nerve and travels to the brain. We've got 1.22 million ganglion cells per optic nerve. So just for comparison, we've got 30,000 ganglion cells per vestibule for the vestibular system.
Wow.
So 30,000 versus 1.22 million. I know I'm biased, I'm the eye doctor, but the anatomy is telling us something, right? So when I look at these cases and I say, okay, nature's not dumb. Why would nature give me nearly half of my brain for visual machinery? And yet we've kind of dumbed down the visual metrics to 20/20 on an eye chart. That seems like we've really done a disservice to visual function. And it's really interesting. If you actually videotape.
That's such a good point.
Yeah. I mean, if you actually videotape somebody reading the 20/20 line from 20 feet, the letters are actually not that far apart on the chart from the first letter to the last one. If you actually record them reading the 20/20 line, you don't actually visibly see their eye move because it's within their span of recognition. Yet if you get somebody to read, you see the eyes moving. Like they're jumping around. They're making what we call saccades. So saccade, being in Canada, we're bilingual. My poor parents, they tortured me. I was raised speaking Gaelic. I learned English when I was probably about 4. Then I was tortured with French, and my wife is Turkish, so I'm tortured with languages. But French, I mean, and it's kind of ironic now because I learned French in Ireland, wondering why the heck would I learn it? I mean, in the background behind me, you can see the Irish flag and the Canadian flag. And I remember when I came to Canada, I told my mom that French is the other official language for Canada. She just started howling and said, "I told you should have learned French," which I did. So it's a good thing I did. But the term saccades. So when I make an eye movement, so if I go from point A to point B, point A to point B, that seems like such a basic eye movement. But when I'm looking at point A, I have to be peripherally aware of where point B is in order to know where to land my eye. So that peripheral awareness is really, really, really important. And it's got nothing to do with acuity. It's got nothing to do with 20/20 on an eye chart. So the term saccade comes from the French verb saccader, which means to jump. That's where the term actually comes from. So when you talk to concussion patients, and today I might sound like I'm a little bit tired because I was in the clinic all day seeing patients, which is actually my fun day, but I'm an introvert by nature. So when I come home, it's like, I'm drained, right? But the really interesting thing was one of the first sentences I say to all my patients when they come into my clinic, before I start jumping into testing and diagnostics and everything, I sit them down, I lift the chair up to my level if they're shorter, because I always remember that doc who saw me as a kid. Mm-hmm. And the very first thing I'll say is, there's a new concept in healthcare called talking to your patients. We're going to have a conversation. And I spend a lot of time on case history because if you're smart enough as a doc and you really listen to what the patient tells you in their own words, they will tell you what the problem is. Mm-hmm. So these patients will often say, I can see there's something not right with my vision, but when I go into busy areas like grocery stores, malls, Walmarts, and Costco's, if I look straight ahead, like all that motion really just bugs me. They're literally pointing to their periphery. So I sit there and go, they're 20/20 in the eye chart and they're pointing to their periphery. I wonder which part of their visual system is the problem.
He's got to know the Costco story with Terry. Did you ever hear that story?
No.
Did Dr. Rochester?
I don't even go to Costco anymore. It's so bad.
We actually call it the Costco test at work. We say, when the patient says, am I ready to go back to work? I'm like, did you pass the Costco test?
Yes.
Yeah.
Can you last for more than an hour at Costco?
Well, because you know what it is. I always say this. They don't label their aisles, so you spend more time left, right looking, and the ceilings are so high. Mm-hmm. And then people are like coming towards you. It's crowded. It's a very crowded place, and you're maneuvering around all that. And then you have to try to guess, where did Costco put that item you need today? Because they moved it.
So what I'm hearing is you have to make a lot of eye movements.
Yes.
Oh, okay.
You never heard the story about Terry bonking out on sitting on the pallets of sugar? Dr. Rochester didn't tell you that I had to go rescue her?
No.
Yes.
Yeah. Oh, dear.
We've had that experience here where Terry has failed the Costco test as you speak to it, as being so.
I've actually had several patients who have had borderline anxiety attacks in those areas. All joking aside, those patients, when they go into, I always think of, you got your rest and digest mode and you got your fight or flight mode. And we should all be kind of in the middle. And yeah, if I get chased by a bear, I want to be able to run. And if I'm eating chips on a Friday night watching a movie, I want to chill. But if that peripheral, so let's go back to the anatomy question that you asked, Drew, because that's a really good point. If we say half of the brain is visual machinery, and most of that visual machinery, by the way, is not for that small area in the center of your vision that you use for detail. Most of your visual field is actually peripheral and for motion. So if we say, okay, nature's not dumb, most of my visual field is not for the eye chart, it's for peripheral motion detection. Why would nature do that? Well, it's your threat detection system. Right. It's, if I'm walking through a crowd and there's 40 people around me, I can't look at everybody. I have to use my peripheral awareness to figure out where things are. So it's kind of like your visual sonar. It allows your brain to figure out where you are in space effortlessly. So it's more a brainstem function. Like when you breathe, you don't think about it when you breathe, right? It's kind of like your visual sonar. And I think when you listen to these concussion patients and they say, I go into this area, there's a lot of peripheral motion, there's fluorescent lights, there's a fan on the ceiling moving, there's people moving in the periphery. And sometimes I'm taking a case history from a patient, and we're kind of like Italians. The Irish tend to move our hands a lot. And sometimes the patients will just go, no offense, can you stop moving your hands? And I actually do that on purpose. I want to see if they stop me.
Yeah.
Right? Because when I'm moving the hands, it's peripheral motion, right? And I sit there and I go, okay. And one patient actually told me, she said, I went into this Costco and it was around Christmas time, of course, because it was worse. She said, I was in there for about 10 or 15 minutes and I literally turned to my husband and said, we need to go, right? And he didn't understand the urgency of that statement. He said, okay, yeah, I'll just be a couple of minutes. And she said, I literally ran out of the Costco. And she said, if there was 3 people in front of me with firearms, I would have knocked them over to get out. Like I needed to get out. It was a visceral fight or flight reaction.
I relate to that.
Yeah. We don't do that anymore. We don't do Costco's anymore because Terry can't. Next question that I had, statistics wise.
Yep.
You speak to the fact that 70% of patients with PCS have ocular function problems. Can you talk to that a little bit, please?
The number is, I think it's 69%, but you're correct. And I think there was a paper published by, the name is Christina Masters. Probably got her. I probably butchered her first name.
University of Penn.
But she did a study on teenagers. So she looked at kids between 13 to 19. And she looked at 100 teens who'd had concussion and were deemed post concussion syndrome. So they were prolonged symptoms. And there's probably about 10 or 15 different types of eye movement disorders that you can diagnose. Basic ones like convergence insufficiency, tracking problems. But she used the most common 3. She looked at saccadic dysfunction, tracking, accommodative problems, so my ability to focus from distance to near quickly, and then convergence insufficiency. I can't, follow my thumb towards my nose as I bring it towards my nose. And out of those 3, her end conclusion was that 69 out of the 100 patients had at least one of those 3 areas significantly deficient. There was about, I think, 16 out of 100 that had all 3 deficient.
Wow.
So if you just said just one was deficient out of the 3, 69%. And that's where that very much jives with what we see. And I don't know if we're seeing a biased sample in the clinic and we just see the folks who aren't getting better all the time. But, patients that come to us, as soon as they say I'm light sensitive and I'm having trouble with peripheral motion, I mean, invariably we find in 90% plus of them, there's significant eye movement issues going on that need to be treated.
How about you, Terry? What you think there?
So I know that the convergence is a problem in the saccades, but I'm not sure about what was the other one you mentioned?
Accommodation. Now that is usually something, so as we all get a little bit older, as we all are, and usually around 40, you start to say, geez, my arms aren't long enough. I need reading glasses. That happens to everybody, right? So accommodation is usually a factor if you're probably about 37 and younger, because we tend to naturally lose accommodation as we get to 40, 45 to 50. So I would say in what we call the presbyopic population, so certainly patients over 55, accommodation doesn't play really a big role. So it's usually convergence or saccadic tracking are usually the 2 issues in patients over 55.
Yeah, my eyes are a big problem.
Tell me about what you notice.
Okay, so I can't sustain reading for very long. I can read, and I do read, but I will eventually, first thing I notice is that start rereading it and losing focus and comprehension.
Yep.
And then I'll notice that it looks more blurry, sometimes double vision's coming into play. If I pushed it, which I usually stop at that point, but
Yep.
if I pushed it, I get what I call the wave, and everything looks like it's kind of drifting onto the page now.
Yep.
And I would never be able to tell you where I was. So I use what's called an Easy C reader.
Yep.
You know what I'm talking about?
Oh,
It
yeah.
highlights the line.
Yeah. Some patients will actually have the software actually say the word to them as well from an auditory standpoint. But to your point, so imagine, and all of that is there are things that I hear from my patients all the time in the clinic. It's not like, they're all going to a bar somewhere to collude about their symptoms. They all come in with the same symptoms. I hear almost the same thing from every patient. So what's interesting is we actually had a 10-year-old kid in the clinic a couple of weeks ago. And what we noticed was, the kid was struggling with school. There was a history of a concussion. There was no real developmental factors. The kid had been labeled as, needs to work on his reading. He's been tortured, sent to a tutor, all the rest of it. And during the consult, the mom is leaning forward and, she's taking lots of notes and she's into it. And the dad is sitting back and he's got the arms folded. And the body language was telling me he ain't buying any of this. So I stopped about halfway into the case history. And I just said, I'm remaining polite because I believe dads are awesome. We just think differently. And I said, I think I'm missing some connection here. I said, is there something I'm missing that I haven't touched on? And he just said, no, he said, everything you do makes sense. But he said, I just think he needs to try harder. That was the phrase that came out of his mouth. And it was interesting because if you look at the symptoms of ADD and you line up the DSM-5 criteria for ADD, and then you line up the symptoms that will occur when your eyes are not teaming properly, there's about a 65 to 70% overlap in the symptoms.
Wow. So what do? We give him Ritalin.
Yeah. Now, if you look at the DSM-5, it actually, one of the opening sentences in the DSM-5 says, in the absence of other neurosensory disorders, the following symptoms apply for a diagnosis of ADHD. In the absence of other neurosensory disorders. Well, geez, if vision makes up nearly 50% of the brain's neuromachinery, and I have an eye teaming issue, I'm pretty sure that qualifies as a neurosensory disorder. Going back to what you were describing when you see, what triggered me to talk about this, we had a really, really awesome consultant who came into our practice a couple of years ago. So a big shout out to Tony Bristol in California. She actually designed a visual for parents to look at so they could actually experience what the kid was seeing.
Oh, I would love for that.
And here's why.
So
because
cool.
I can sit there all day long and talk to a parent and say, your kid's got convergence insufficiency and saccadic tracking difficulties. How much of that do you think actually resonates with the parent? They're just words, right? Whereas if I sit the parent down and I use this tool while the parent is reading, I can literally mess with the print while they're reading.
Oh, man, I would love for people to see that.
And I literally, and this might sound cruel, but I force them to read an entire page. And then when they get to the end, I say, so what was the story about? No idea.
They got no answer.
Yeah.
And they probably got a headache at the end of it too.
Yep. And what was interesting is the dad in this consult, to his credit, I could see he was kind of tearing up. I'm like, I hit a nerve. So I called one of my team and they came in and took the kid out and, played some games with the kid or whatever. And I said, I really didn't mean to offend you. And he said, no, he said, everything you did was awesome. He goes, I just, hopefully I can say this on the podcast. He said, I feel like a real ass. I said, why? He goes, do you know how many timeouts I gave my kid because he was struggling with reading? And he was genuinely he was choking up. He was upset.
Yeah. He was upset with himself.
Well, and this is where, when I told this story to my wife, she goes, yeah, well, of course. And I love my wife. She just tells things the way they are. She goes, men are single-celled amoeba. I said, what do you mean by that? And because I'm getting offended. She goes, no. Men don't go from A to C. They have to go from A to B to C to make sense of it.
Yep.
So what was happening in that situation was that the dad didn't see the connection, but when you spelt out to him what the connection was, he actually engaged more. He engaged in therapy to rehabilitate this kid actually more aggressively than the mom did.
Wow. Yeah. That's a great story.
That was kind of cool to see.
I would love to get my hands on that so that people can see, because I'm always saying, I wish I can explain it, but no one can really understand it unless they're.
Well, I could send you a movie file of that. How's that? And then you can just play that. People can play it and say, what's it like to have the problem? Press here.
That would be great. I also see it in my world. Like I have to use a cane for my proprioceptor just to figure out where I am in space because my vestibular is damaged along with my vision. And they found like my muscles are stretched in my eyes. So they're recommending possibly surgery. I went through therapy and all this other stuff. I'm not happy, not about that. But when I am looking down at a curve, I have to wait to make sure like I'm seeing the right curve or touch it with my cane to go.
Now, do you want my opinion on the surgical piece?
Yes, that's why I mentioned it.
So here's the thing. If we're not talking about strabismus, which I don't think we are, we're talking about convergence problems, eye teaming problems. What's interesting is when somebody can't converge. So if I take my thumb and I move it towards my nose, both my eyes should move in smoothly. In a lot of concussion cases, the patient has trouble converging. Both eyes don't work together as a team. But what's really interesting, when you cover one eye, the other eye can move towards the nose, no problem, monocularly. If I cover the other eye can move towards the nose, no problem, monocularly. But when you get both eyes to move together, they can't converge as a team. So my question then is, how's that a muscle problem? Here's the thing. If I have trouble teaming my eyes together, but when I use one eye at a time, I can move my eye in every direction. The problem's not with the muscle. The problem is the brain's ability to control the eyes. Yeah, you can move towards your nose, no problem. I can see it. Now look at your thumb with both eyes open and move it towards your nose. And my guess is that's going to be hard for you to do. Yeah.
Splits.
Right. So this is where, and I'm not anti-surgery for eye muscles, but when you look at this and you say, hold on a second, the problem's not with the eye muscle. The problem's with the brain's ability to control the eye muscle. So why on earth would you go in and cut the muscle? It makes no sense.
Well, thank you for that. Because I really did not want surgery. And that makes a lot of sense to me. So what do you do?
Well, this is where vision therapy comes into play. And again, vision therapy, I like to use the analogy of physiotherapy and orthopedics. So for example, if you had a leg muscle problem, would the MD say, go straight to surgery or see a physio first? Probably see a physio. Okay. Yeah. So let's just say you tried the physio and you went from like 1 out of 10 to 3 out of 10, but now you need the surgery. You went for surgery. What would the MD say after you did the surgery? They'd probably say, go back and see the physio again, right? And nobody questions that logic because it makes sense. Now, take that into this world and you say, okay, so the patient has an eye teaming problem. Should we jump straight into surgery? Probably not, because as soon as you cut that extraocular muscle, surgically, you lose the proprioception. You lose that ability. So I don't know if you're going to be, when you're podcasting this, if people can see me, but I know you can see me right now over Zoom. But if you watch my eyes, I'm going to make myself see double. So you should see my eyes, they're crossed now. I'm going to look at the left image that I'm seeing, and I'm going to make the left image move. You should see my right eye going in. You see that?
Yep.
Yeah.
Now I'm going to pull it back. Now I'm going to hold it. I'm going to look at the other image, and I'm going to make the other image move. So now my left eye is turned in, but my right eye is straight, and I can feel that pull, right?
Yeah.
And then I'm going to let the eyes go straight. So who is in control of my eye movements there? The muscle of the brain.
I would think the brain.
Yeah, the brain's the boss. So when you cut the muscle, you actually lose that ability to feel what the eye is doing. So in my mind, the first step is vision therapy. And what vision therapy is designed, optometrists do vision therapy with lenses, prisms, tints, but they're using what I call biofeedback exercises, just like the one I showed you. What you're essentially doing is you're reteaching the brain how to control the eye alignment. And it is a slow process, just like when you see a physio or you see somebody for a rotator cuff issue, but it's really biofeedback exercises. And I always tell the other docs and the therapists, so a shout out to our therapists and docs of VIEW, they do a fantastic job with their patients, but we all know that any exercise that doesn't have a biofeedback component is probably a useless exercise. So what I mean by biofeedback is the patient knows when they're not doing it right. They don't need somebody to tell them.
Yeah.
If I'm looking here, I see one thumb, but I see two of you in the background. So I know I'm using both eyes together. Otherwise, I wouldn't see two images in the background. So teaching the patients these visual skills and allowing them to gain these visual skills, it's crucial. You're really teaching the brain how to better control the eye. So we see with the brain, the eyes just send the picture, but the brain does all the seeing and the fusion. Otherwise, why would we have two eyes?
Right. Now, along these lines, I found this fascinating. In one of your lectures, you spoke to the fact that the neck and the back, they need to get sorted out before vision therapy results. Otherwise, the results in vision therapy are less than 20% effective. Why is that?
Well, I think one thing I would say, I mean, the stat on that I'm not sure about, but I do agree with the philosophy of that.
Yeah.
Is what I notice. I mean, when I talk about neck is, I actually think it's an accessory ocular muscle. People laugh at me when I say that. They go, what do you mean the neck's connected to eyes? Well, if I look off to my right, I'm probably going to look maybe 10 or 15 degrees before I start to move the head. So as soon as I move my eyes a little bit, 15 degrees out, I'm going to start to move the head. So there's got to be some sort of connection between neck muscles and visual muscles. And what I always tell patients is there's a philosophy, bigger muscles teach smaller muscles how to move. That's a very, very common saying in any form of rehab. So if I have an eye stability problem, so let's just say I'm keeping my head still, I'm trying to follow a target, I'm trying to track, and I have a hard time tracking that target, one way I can immediately get better at that is hold the target still, but move my head instead. And you'll find that the tracking is actually more smooth. Why? Because bigger muscles are teaching smaller muscles how to move, right? The neck is, and again, I'm not a neck specialist, but I do know a lot of neck people that I refer to. And I always refer to the neck, that, the neck is kind of the base of the pyramid. If you don't get that stable, everything else is going to be off. Also, the SCM muscles, your sternocleidomastoid muscles, those big muscles right in front of your ear that goes right down and attaches to your clavicle. Most concussion patients, the SCM muscles contract and actually pull the head forward. So a lot of concussion patients, you see this forward head posture. The problem with that is, I think about 5 or 10 degrees of forward head tilt, and you're adding about 15 pounds of extra weight onto the muscles of the neck. There's a lot of blood vessels that go through the SCM. You got, there's a huge amount of blood supply that goes up through that same area. And there's also the vagus nerve, which is your number one toned down nerve. It's your parasympathetic nerve. So if if both of those SCMs are contracted and it's pulling your head forward, now you're sending the patient into a fight or flight. You got a reduction in blood supply, and you're going to try to do vision therapy with that patient. It's going to be a mess. So from my perspective, I wouldn't say the neck has to always come before the vision therapy, but in the more serious cases, yes, I usually say I ain't touching you from a vision therapy standpoint until we get the neck sorted. I may prescribe lenses or prisms that might get the patient from seeing double to not seeing double, but I'll hold off on the therapy component until the neck is in good shape. In some patients that aren't as bad, I'll tend to do them in parallel as long as I'm communicating with the neck person. But neck is a crucial area for sure.
Very interesting, because I went through a lot of vision therapy and I was seeing a regular chiropractor. Love my chiropractor. Had a lot of gains and a lot of
you had other issues too from your fall.
I had a back problem from the fall. So that was very helpful. But wound up going to see an upper cervical recently. It's only been like
6 months, maybe.
Yeah, maybe about that long, if that long. And my x-rays are already showing marked improvement. And now I'm thinking, as I'm listening to you, maybe I would fare better in vision therapy this time. Because anytime I was working with Dale over at the Neuro Center, I need to take a picture of you. I need you to see your head. You're constantly, do you really think you're straight? I'm always, my head's always.
Yep.
I'm like, as I'm talking to you, I'm trying to like straighten my head. Right? Straight. And this is better than it was, you know? So I'm just thinking maybe I would have more success with it this time.
Interesting, Terry. Maybe I have to look into that. I got a sort of a silly question to ask here, but it's a pet peeve of mine at the same time. You seem to be very candid. Why does it seem like every darn doctor's office you go into has got fluorescent lights?
Thank you. So talking about lighting. So we actually have a test in our office where I was talking to James, the doc that we've been collaborating with. And it was interesting because we actually have a flipper in our office where we have a yellow filter and a blue filter. And yellow is long wavelength, blue is short wavelength. And what's interesting, whenever you have a concussion patient in our chair and we show them a yellow filter versus a blue one, they typically love the blue one, hate the yellow one. Almost every time. You'll get the odd patient that will be neutral, but I would say 9 out of 10, if their concussions occurred within 2 years of the consult date, they typically will choose the blue and absolutely hate the yellow. Like they will recline and go, I don't want to look through that. So what's interesting is fluorescent lights, they have a low grade flicker to them that most of us can't see, right? But it's called a critical flicker fusion frequency. So there's a flicker about 65 hertz that around that flicker rate, we no longer perceive flickering and it looks like a stable light. If that peripheral visual system's affected, that threshold changes in concussion patients. So I've had concussion patients sit in my chair and say, doc, as I'm looking at you, I can see flicker from that light. Do you see that? And I'm like, no, I don't. So they're perceiving flicker when I don't. Now, it's also the wavelength of light as well. Now, personally, if you walk into my exam room, the walls, they're actually painted blue, and the patients find that very toning down. I have fluorescent lights, but I'll usually only turn them on when I want to test because I want to see if they aggravate the patient. But to your point, yeah, I mean, most hospitals, most clinics, you walk in there, it's all fluorescent lighting. It's the worst type of lighting possible for a concussion patient. Our waiting room actually has very low wattage incandescent bulbs, but they're uplighters and it's diffuse lighting on the wall. So it's actually very easy for the patient to handle it. But I'm continually shocked how many offices. I mean, I've got a really funny story very quickly of a patient that came to see me, and she's actually a family doc. She came to see me as a patient. And she said she went to see her family doc, and she's waiting in the family doc's waiting room, and there's literally black and white patterned stripes on the carpet on the floor. And she literally stood up and she goes, I tried to walk, and she's like, I literally tipped over because the peripheral pattern as I was walking was so disorientating.
Confusing, yes.
And the irony of the story is the patient ends up going in, who's actually a family doc, goes in to see her family doc. And when she tells her these symptoms, the family doc refers her to a psychiatrist because she thinks she's losing it. It's like, no, this patient's complaining about a bona fide visual problem that you don't realize is actually a visual problem.
And sometimes the pattern on the walls too.
I've had patients tell me that, when I'm looking at the floor, it literally looks like the floor is either tilted or slightly moving.
Well, I've said that a lot to him before. And I'll check in with him to say, is this floor crooked? Is it me or is it the floor? I have to find out from somebody whose eyes are working. So I frequently will check in with them.
That is a fact. Mm-hmm. That is a fact.
Yeah. Do people say too for lights that they hear them?
Yes. And you know what? I actually believe that, and again, I'm not an audiologist, I'm not an ENT, but I have enough patients that come to me who will complain of either tinnitus or by the way, I think most of the tinnitus is actually connected to the neck, not to the hearing, because I think when the neck muscles get more contracted, they compress feeder muscles. The rectus capitis minor muscle that goes up to feed the ear. But what's interesting is
that makes sense.
I think, and this is one of the holes in my gas tank that has stayed with me. Mm-hmm. So I think I've resolved pretty much all my visual issues. My memory's pretty good. My hole still left in my gas tank is sound. I will hear a pin drop in the basement. It drives my wife nuts. Right? I hear everything, right? To the point where it's like, it's annoying. It really is.
Me too.
And if my wife is talking to me and the TV's on, you got to mute the TV. What are you saying? I can't multiple auditory. I can't do it. And I think what's interesting is I think that's a figure ground problem. And what I mean by that, myself and a shout out to Dr. Cunningham, who's the other FCOVD optometrist in our office. Both of us often go down a rabbit hole when we're talking about, what's causing certain symptoms in certain cases. He's kind of the yin to my yang. I always joke, if you ever watch the movie The Matrix, like he's Morpheus and I'm Neo, right? Mm-hmm. He's always doing the higher level thinking. And I think what's interesting is whenever we get into a debate and we're not sure what the answer is, we always just both default to, yep, it's figure ground. And what I mean by figure ground is where I'm looking, where I'm fixating, is the figure, and then the ground, the background is the background. So if somebody has trouble figuring out the figure from the background, it's a figure ground problem, right? And almost all vision problems in concussion are figure ground issues. Now you can break it down by diagnosis, but ultimately it's a central peripheral integration figure ground issue. I actually think the same type of deficit exists in the auditory system. Because, when I'm listening to somebody talking and there's a TV on in the background that shouldn't bug me, but boy, it really bugs me. Why? It's almost like the auditory signals they're clashing. I'm not able to discriminate one from the other. And I actually think there's an interesting link between the two. And Drew, maybe you heard this in one of the lectures, but there was an interesting paper published by PNAS, which showed there's a muscle in the inner ear called the tensor tympani. And what they showed in this study, and maybe I'm just a nerd, but this was like super cool. When you look to the right, the muscles, the tensor tympani muscle behind the eardrum contracts and it actually moves the eardrums slightly to the right side. I thought that was just like, that's wild. And they only showed that probably, I think it was like 2016 or 2017. Like that wasn't that long ago.
Yeah, that is cool.
So I'm sitting there going, holy crap, you're telling me the eyes literally move with the ears? Well, that makes sense, because if I'm looking to my right to talk to somebody, I'm probably auditorily attending there and not over here.
Right.
So the brain is constantly looking for efficiencies. So what I started to notice is patients that I assessed when they had a gait issue. So if you got them to walk and they were like leaning off to one side or drifting off to one side, it's almost like they're visually ignoring the other side. They typically had auditory localization problems on the same side as the vision problems. So I actually think that visual peripheral localization skills and auditory peripheral localization skills are probably intertwined. And these will be the patients that, you sit them in the chair and you get them to close their eyes and you take a little bell and you ring it somewhere and you say, touch that with your finger. And on one side, they nail it every time. On the other side, they're like a foot away from it. And that's typically the same side that they're having more trouble visually from a peripheral awareness standpoint. I don't think that's a coincidence. And when I go back to my PhD years, and my poor wife, she tolerates me. She said, I finished my PhD and my postdoc, and then I decided not to be an academic full-time and open my clinic. And she said, wait a minute, you did 4 to 5 years as an academic to decide that you didn't want to be a full-time academic. I said, correct. Because I have a healthy respect for academia, but I have come to the conclusion that it's the docs in the trenches figuring these cases out that come up with the initial key ideas, and the researchers will eventually latch on and kind of figure it out, publish on it. But the actual core ideas that benefit patients, those sparks happen in the clinic. That's where the magic occurs. And that's where I want to be. I don't want to be in an ivory tower applying for 50 grants that I might get one of them in a couple of years, right? That's not how I want to function. But what was interesting is when you look at these patients, it's the figure ground issue to me is intriguing. It really is.
I love the fact that you are lobbying to remove the tag mild as it pertains to concussions. So many people are struggling with it.
That's a big pet peeve.
Right.
Yeah.
Yes. And mine too.
Oh, yeah.
And do you think because this term is utilized a lot, that concussions aren't taken seriously enough just because of the term mild?
Yes.
Yeah. And I think, to be honest, I mean, when you look at the nomenclature of mild, moderate, and severe traumatic brain injury, that was really pertaining to either the presence or absence of findings on imaging, CT, MRI. It was, so when they say it's a mild traumatic brain injury, they don't mean that the injury is mild. What they're saying is the objective markers on neuroimaging is mild. And to your point, that's actually, it's a pity they use that term, because everybody just hears the mild and stops thinking.
No big deal.
Yeah, happens all the time. And it's
right?
Laymen too do it, like not just doctors. Like if you say, I have a mild concussion, they think nothing. Everyone does it. It's just the term mild.
Yep. There's technologies like diffuse tensor imaging. I mean, a big shout out to Michael Early. He's a professor at Ohio State who's doing a lot of really cool. I mean, I always joke that I'm jealous of him and he jokes that he's jealous of me, because we both I do the clinical stuff where I'm kind of getting my hands dirty in the trenches. And he's doing the neuroimaging equivalent where he's looking at, what parts of the brain light up and what don't. And he's gone way beyond MRI CTs. He's gone to diffuse tensor imaging. He's gone to other forms of imaging that can really help to functionally see what's going on in the brain. I think once you go beyond conventional imaging, those types of technologies are showing deficits. So I think it's just a matter of evolving and having more access to these tools. And I think in Canada, probably a different story in the States, but in Canada, actually, yes, our healthcare system is universal and all that sounds great, but it doesn't sound so great when you're waiting for 9 months for an MRI. There are limitations to our healthcare system here. And I think, access to more useful technologies or appropriate technologies for brain injury is very much an issue up here. And I think from that standpoint, we see a lot of, patients who've been involved in car accidents. They go through the HCI system up here, and then the insurance company says we're going to send you out for an independent medical exam, which quite frankly I laugh at, because the doctor's literally paid by the insurance company. So, and I'm not saying the doctor's not ethical, but it's not independent. They're being paid by the insurance company. So a lot of these doctors will do kind of the basics of a regular eye exam and not do the eye movement testing, and then tell the patient, well, there's nothing wrong with you because I didn't find anything.
I had that a lot.
Now the patient is snookered because the insurance company is not covering them. Mm-hmm. They're basically more or less being accused of faking it, which is tragic. And then we wonder why the depression indexes go up in these patients, right?
We have a little bit of experience, unfortunately, with the IMEs and vision, a whole nine yards there. Now, doctor, I have read that you have lectured over 750 times over the years across the globe, trying to help educate as many people as you possibly can about PCS and reading and learning difficulties that are related to vision concerns.
That's awesome.
And that you actually make an effort to publish everything that you can think of in an effort to get more information out there and understanding. And we spoke about it a little bit earlier in terms of the medical community lagging behind. What are some things that you think that could be done to actually help kind of get them up to speed a little bit better?
I think, I shout out to Dr. Rochester, who's obviously put us in touch. I mean, there are some really really, really good MDs out there that really do care. So I want to put that out there first and foremost. But I think, tools like, for example, I mean, the book that myself and Dr. Singman wrote a chapter in, it's Neurosensory Disorders, Mild Traumatic Brain Injuries. It's actually a book for doctors. And each chapter is on a different topic. You got a chapter on vestibular dysfunction in concussion, visual function in concussion. Now, of course, whenever they sell books for doctors, they jack up the price to like $500 because apparently we're all loaded. That should be sitting on the desk of anybody dealing with concussion from a healthcare perspective. So that's number one. Number two is I wrote a book for the public on, this was actually for moms and dads. Actually, unfortunately, without getting into a whole teary story, when I was going through my PhD, actually a couple of weeks for my PhD defense, my mom was a nurse. She was my rock, but she developed ovarian cancer on a Monday, passed away on a Friday, and I didn't get to see her because I was flying home. I was in the air when she passed away. So she really made a big deal, a big difference to me in my life. So I wrote that book to kind of honor her and make sure that I got the message out there to parents, so other parents of kids with learning issues. So Learning to See, Seeing to Learn is on Amazon for like $10. And believe me, Amazon makes the money, not me. But it gets the message out there so parents can read this, and it's on Amazon, Audible, Kobo. And it was funny. I was just saying to Drew earlier, I wrote this book and I put it out there and it was sold a whole bunch of copies. And then I realized, oh, I'm such an idiot. I didn't put it on Audible.
Right.
People like to listen to this stuff if they have a problem with their eyes. How silly can I be? So eventually we got somebody with a cool voice who did the Audible stuff, and that's cool. So it's all done now. But to your point, trying to get this word out to docs. I mean, I've lectured in Ireland, I've lectured in the UK, I've lectured in Canada and the US. I mean, I've been down to Hopkins, I've been to Pennsylvania, Ohio State. I mean, and actually my old PhD supervisor, who's now at Berkeley, actually invited me out to Berkeley to speak. So, I mean, I've spoken at a number of venues, and my message is always the same. It's the best doctors. The difference between an average doc and a really good doc is that the latter knows when to get other people involved. Stop trying to be everything to everybody. And I think that's a really, really core message, because your ego is going to get in the way of improving the patient. The thing that really frustrates me sometimes, and this goes for ODs, MDs, chiros, any healthcare profession, you got to know what you know, but you also have to be aware of what you don't know. My philosophy is, if a patient's sitting in my chair and they have a complaint, they have a subjective complaint, and I can't find the answer to it, my answer is not to dismiss their complaint. It's to send them to somebody who I think could help them other than me. And I think Eric Singman, who's the MD PhD I talked about, so he's a neuro-ophthalmologist. He's quite frankly a breath of fresh air, because he's one of these, humble. Imagine being like the head of neuro-ophthalmology at Johns Hopkins, an MD PhD. This guy could walk around like a peacock and an ego the size of Mount Everest. He doesn't. He's one of the most humble people I know. So that book chapter that we got in the medical textbook, he was asked to write that book chapter. He reached out to me and said, "Hey, Pat, I don't know what I'm doing with rehab. I'm an acute care doc, but you know what? I got a really good idea. How about we write this together? So you talk about the rehab, I'll talk." Like, he's so collaborative.
That's great.
And that idea really got out there. And I think that's what we need more of. We need docs to, put down the armor, put the ego aside. Like, I mean, James, who reached out to me, and he probably feels bad. He emails me about once every other week. And I love emailing him back, because he's eager. He wants to know more and more and more. And I applaud that mentality, because not every, how do I sound kind without sounding crass? Just because you're licensed doesn't mean you're good. How's that?
I'm glad that you're shouting out to him for it, because I thought that made the biggest difference for me, for having him as my doctor. I knew that he would stop at nothing, and if he didn't know, he would find it. And I saw his passion, and I saw his care. And after 90 days, because it was a work injury, I could have easily have just said, "That's it, I'm going to go to another doctor." And I stayed because I knew I was in the best hands, because he did do that. Yep,
absolutely.
Yeah. You don't find it. It's very rare.
Well, it's all about having a quarterback. And I think having that person, and I mean, yeah, James is an MD, but it doesn't matter what discipline there. You need somebody to be the quarterback. Ideally, that should be the family doc, you would hope. And I think they're the folks that probably need the most support. I'm not going to say education because I don't want to slam them. I mean, the family docs are put in a really tough position because they don't get a lot of support in this area. I think it's getting those resources to them to say, hey, somebody comes to you, what should I do with these patients? And I think it's feeding that natural curiosity and making sure, but also making sure that it's the right healthcare professional at the right time in the right sequence. I think that's the important thing, because to my point about the neck and the vision, but also within each treatment area domain, like for example, in the US, there's you can be board certified in vision therapy. So in optometry, there's the FCOVD. So you can be an optometrist, but you can be an FCOVD board certified optometrist in visual rehabilitation. That doesn't exist in Canada. It's not formally recognized, but we do have probably 40 optometrists in Canada who are board certified in this area. PhDs are great, but they're not clinical, right? I mean, people say, oh, it's great, he has a PhD. I'm like, that doesn't really help me in the clinic. Me knowing statistics doesn't help me in the clinic. If you're an FCOVD, if you're a board certified optometrist, so there's actually a website, www.covd.org. If you go to that website, there's a big button that says find a doctor. You click on that. And when you're doing the search, just make sure you tick that little box on the bottom that says only show board certified doctors. That'll give you a list of optometrists who are not just optometrists, but they've done extra training in visual rehabilitation. So you have to be board certified, but you have to recertify every 4 years. So in Ontario, it's not in place right now, but we are pushing for formal specialties within optometry. And I think it's overdue, certainly in this area. It's also about making sure that you have the right person doing the right therapy.
I also would say with that, in our own experiences and in talking with previous guests who had successes, that it's also about a willingness from that quarterback, as you speak to adjust and maybe change the sequences or call an audible. There were plenty of times where Rochester called an audible for you. Mm-hmm. Like, this is not working the way we're doing it. We're going to try this instead, stuff like that. Mm-hmm. I think there has to be a willingness where that is on the forefront of your mind, and it's not an ego thing or a stubbornness thing as well, right? Would you agree with that?
And we actually have a group in Ontario. I want to give a shout out to the Sandbox. So we call it the Sandbox because we all learn to play nicely in the Sandbox. Yeah. It's a group of docs, and we're almost like a group of misfits. There's one guy who's really, really good at neck and back. We've got a doctor of audiology who's US American Institute of Balance Board certified. We've got a psychologist, a neuropsychologist. So we have multidisciplinary people, and the only rule we have is you're welcome to the Sandbox if you don't have an ego. Mm-hmm. If you have an ego, there's the door. So once a month, we get together for about an hour or two, and we have a meal and we have a couple of drinks and we chat. And we informally talk about patient cases. So here's a patient case I'm dealing with. And we don't use names or anything, obviously, for patient confidentiality, but we say, hey, I'm dealing with this case and I'm seeing this. What would you do? And honestly, I would say I've been going to these, once a month Sandbox meetings for probably, going on 8 years now. I think I've learned the most from that. Because when I'm sitting there talking with, it's one thing when I'm sitting there talking with a bunch of other optometrists, but when I'm sitting there talking to a neck specialist, I'm talking to an inner ear specialist, I pick up these pearls that I don't want to do their job, but I need to know, when does that patient need to see you and not me? That's really, really key. And I think I would encourage anybody who's involved in concussion, form your own darn Sandbox and get together with other good people who care.
I think that might be happening over at LGH. I've heard them mention them getting together. I think that's a great idea.
Yeah.
Lancaster General Hospital in the Neuro Center, they call it.
Now, just to be, is LGH Lancaster?
Yeah.
Yeah, I actually lectured there. I lectured there years ago. Eric Singman was there at one point, and there was another lady, she was an OT, Elizabeth Rohr.
Yep.
Yeah, she was my OT.
Yep. Oh, Liz is fantastic. And she actually, she lived in Guelph for a while because her husband's Canadian.
Right.
She did a fantastic job, and she actually had me up there lecture to the folks up there. And I'm very familiar with the LGH group. I think they really have it together, and they're just getting better and better and better all the time.
Right. And they really care. And Dale, she's like neuro PT.
Yeah.
Which I didn't even know that existed. I knew PT existed. I didn't know there was a neuro PT too.
But I know I've actually encouraged James and the folks at LGH to reach out and get an FCOVD optometrist on their team, because I think that's a critical piece, because you can have somebody kind of doing the therapy. You can have a physio or a chiro or somebody kind of doing vision therapy light, but you really want to have somebody who's an optometrist who's board certified in this, really in the trenches with the therapy team, making sure that stuff is happening the way it should occur. I think that's and I've said that to James, and I think it's hopefully their next step.
I wonder if they did that with Dr. Klammer. I think that's the name. I don't know if I know he's a neurooptometrist.
Yeah. And the FCOVD is, just because you don't have that designation doesn't mean you're not a good vision therapy doc. But it's kind of the seal of approval, right? It's the level you get it, they've got it and they have to recertify. So it's something that most optometrists in the neurovisual rehabilitation space will recognize very quickly.
And you said that website was cov.org?
Well, I'll put that in the show notes too for the peoples out there. I'll obviously put all the information here that the doctor shared with us in the show notes, okay? We're getting close to the end here, and I want to respect the doctor's time, but I have to ask you one question here, and then I'll ask you the big question at the end that I always ask everybody. But doctor, where do you want to go with what's the ultimate goal of everything that you are trying to achieve here?
My ultimate goal is to try to get optometry, enough of optometry, involved in neurovisual rehabilitation that it's not a well-kept secret. I think, it should be as common as language as physiotherapy and occupational therapy. And when people say vision therapy, you see people's face just go, huh, what's that? And I think I want vision therapy to become a household name. And I want people to understand the power of vision therapy and what it can do for people. And I think ultimately, and it sounds cheesy, but honestly, I mean this, is vision therapy can change people's lives when it's done properly. It's one of those things where it's, you're maximizing human potential. I mean, all of us are only here for a limited period of time in life. And why would you not want to maximize your potential recovery so that you can have as high a quality of life as possible? And I think that's ultimately where I want to take this, is making all the healthcare professions aware of the benefit of vision therapy.
It's fantastic. Go ahead, Terry. I know you have a comment here.
Oh, just popped into my head. And I was thinking about where you stand with prism lenses.
Yeah, prism lenses. I mean, there's two ways that you can treat a patient. And I always talk about therapeutic versus compensatory. So compensatory or compensatory, depending on how you say it, the wonderful English language. Yoked prisms, for example, I can make the floor look tilted to somebody who doesn't have a problem. So I can make them walk with a certain gait. So if I can mess up a normal person, why can't I use the prism the other way around and help somebody with a gait issue? Makes perfect sense, right? You can also use prisms to bring images together for patients who see double. So prisms, but the prisms are compensatory. When you take away the prism, the patient still sees double or the patient still has an issue. The therapeutic component is getting the patient to be in control of their visual system to a point where they don't need the prism.
Right.
Sounds about right.
What do you think of prism lenses working for a little bit of time and then failing?
Yeah, usually what happens if somebody prescribes a prism and it initially helps, if you do not do vision therapy to reinforce the fusional system, eventually the patient will kind of almost regress back to where they were before, even with the prism. I always view the prism as it's almost like a visual retainer. You put it in place, you get the patient more aligned, but now you got to fix the system. If you just prescribe the prism and you walk away and you say, yep, my job is done, that patient's probably going to be back to you within a very short period of time saying, doc, it helped for a couple of months, but now it's back to where it was before. So that's where the therapeutic component comes in as opposed to the compensatory approach.
Sounds all too familiar, doesn't it, Terry?
Yeah, mine are failing. And that's what happens.
Yeah.
They fail and then I want to just get out of them.
Yeah, because it frustrates you. Now, Terry, you don't know this, but before you came and joined us here, Dr. Quaid told me that he loves the name of the podcast. He thinks it's spot on.
I do.
So
I do.
I'm going to ask him the big question related to that. All right.
Okay.
Dr. Quaid, I want to know and part of this has to do with you being a warrior yourself. What is one or two pieces of advice that you would offer to somebody else who's in the midst of their own battle within?
That's an awesome question, Drew. Two pieces of advice. Let me think. The first thing I would say is assemble your A-team. The three areas that are really important in the vast majority of concussion cases is neck and back, visual, and, wait for it, psychological.
Yeah, right.
Those three areas are the three I'm not saying there's not other areas, so nobody else is going to get upset here, but I think those three areas are the three most important prongs to make sure you put the right people in those pieces, right?
Right.
So my first advice is put together your A-team. My second advice, and this kind of, if anyone's a fan of Jordan Peterson, he's a Canadian psychologist up here, wonderful guy. And he's basically said, in his book, The 12 Rules of Life, one of the rules is view yourself as somebody that needs to be cared for. Be kind to yourself, right? And I think when I think about what I've gone through personally, I mean, I was joking with my older brother the other day. He's still in Ireland, so we talk once a week. And I said, I'm pretty sure I was stuck in a stress response mode from age 8, probably until about age 35 when I finished my PhD. I was just go, 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 go. I was burning the gas tank 24/7 to the point where, honestly, I probably came pretty close to a nervous breakdown, but my wife was smart enough to hit the brakes and say, you need to slow down. And I took time off, spent time with my kids. I took time to look after myself. And one thing, and I'm very open about saying this, seeing a psychologist is not a sign of weakness. It is a sign of strength. You are taking the position where for the folks that have access to it, and I understand cost is a barrier, not everybody has access to it, but boy, that's like, it's the best luxury you can give yourself. You can talk to somebody else with no hold bars and say whatever the hell you want, and they have to listen. And they can't tell anybody else.
Yeah.
The freedom of that is massive, right? So having that capability, we all get into this mindset of, and I mentioned earlier that there's some, speaking of stats, Drew, I know you're a stats person. There's some stats of Ireland. I love Ireland. I love my home country, but there's some stats from Ireland I'm not proud of. They've got the highest suicide rate of all European developed countries. For every 5 suicides, 4 out of 5 are males. And every suicide is tragic, to be clear, but 4 out of 5 are males. No one's talking about that. We play a lot of impact sports, rugby, hurling, Gaelic football. A lot of that stuff has no protection in place. I know personally 3 close friends who've committed suicide over the years. My dad was in the military dealing with a whole bunch of that stuff. So when you look at these statistics, it's pretty clear to me that there's a lot of people out there not seeking psychological help and not seeking people to talk to and people to be able to not vent to, but to be able to say, hey, this is what I'm going through. Am I crazy thinking this? And I think having that outlet. So going back to your question, Drew, my second point would be absolutely what Jordan Peterson says. And the reason why I love his podcast is there's a lot of stuff out there. And I have a daughter, she's 9. Women should be elevated 100%. There's very little out there for guys. And when you see 4 out of 5 suicides being males, it's like, okay, this is an issue that society needs to talk about. So I talk to all concussion patients when I say this, seek psychological help, have that person on your A team. But especially if you're a male, we tend to be, and my wife jokes about this all the time. She goes, males are not social by nature.
That's true.
We're solitary beings. I can count my friends on one hand, my close friends on one hand, right? The people, when I say friend, it's like somebody I can text. My definition of a friend is somebody I can text anything to, and I know they won't judge me for it.
Right.
Might be a joke. It might not be a joke. That's a friend. And you look through your list, it's like, maybe 3. My wife, it's like she's got a Rolodex of like 50 people and she talks to them all the time. And it might be her personality. She's an extrovert as well, but I don't think that's too unusual. So I think guys need to be, as Jordan Peterson in his 12 rules of life, like treat yourself as somebody that needs to be cared for. And I think that would be my second rule.
I don't know who you got for your Audible reader, but there's no way they have the Ireland accent and it could be better.
It's like half Irish, half Canadian,
I think
right?
You totally should do your next book.
When I went to England the first time, I'm not kidding when I say they couldn't understand me. I was like a Newfie on steroids, right?
Yeah.
They had no idea what I literally had to repeat everything 4 times. I had to slow down. I called my dad one day. I was all frustrated, and he just kind of joked and said, "It's okay, son. They're a little bit slow. You got to slow down." I said, "Okay, Dad." So what was funny was I had to change. I literally had to change how I spoke for them to understand me. Then I ended up coming to Canada, and amazing to me because I could speak the same way I spoke in England, but if I speak very fast. Apparently, people tell me. But when I go home to Ireland, they make fun out of me because they say, "Why are you talking so posh?" And then within 2 weeks, I'm talking like a newfie again.
Yep.
It works.
Yeah.
It works. But yeah,
Yes,
you're right.
it does.
The accent, I decided not to record myself on the Audible because I think I do speak a little bit fast. And if there's folks trying to get the concepts, I'd rather get the Jordan Peterson voice or the Denzel Washington voice or somebody who's, slower, more methodical. It's probably better.
Terry, you got any other follow-up questions you'd like to ask the good doctor here before we wrap it up?
Forever with
Yes.
Yeah.
Well, maybe if we're lucky, we can have him come back on in the future.
Yeah. So it's great.
I'd be happy to.
I mean, there might be some other things or questions or whatever that comes up that maybe we get him to come back like we've done with some other folks, yes?
Yeah.
Before we go, though, Dr. Quaid, I must ask, can you tell us a little bit about where folks can go to learn a little bit more about the work that you are doing? Definitely want to give you the shout out and point people in that direction.
Thanks, Drew. I appreciate that. The website for our clinic is viewtherapy, So it's www.vuetherapy.ca. Also, we have a book on Amazon. Obviously, this is for parents of kids with learning issues. So whether it's concussion or not, especially if it's rooted in reading or spelling. And the book is called Learning to See, Seeing to Learn. And that's on Amazon. It's dirt cheap. It's like, I think, maximum $10, but there's a lot of good information in there. It's got the addresses of our clinics, but the website is the direct link to us.
That's perfect. And just as a reminder, there's some information and some video lectures that the doctor passed along to me as we were preparing to have this conversation today. I'll make sure that they're linked up as well. Mm-hmm. I definitely think they're worth listening to. I got quite a bit out of it myself. Good. And it's something that I like to think that I know a little bit more than the average layman in this realm, but he still taught me a ton. So I definitely think that that's worth going and checking out. Dr. Quaid, I want to say once again, thank you so much for being a guest today on A Battle Within. It was an honor for us to finally speak to you and to say thank you for your counsel that you offered James Rochester in helping Terry to heal. Appreciate
and today,
it.
too.
Yes. And you gave Terry some ideas today, right? Yeah. About ways to look into things a little bit more differently, right?
That's right.
Going forward. So I'm sure if people don't get something out of this conversation, I don't know when they will. Right, Terry?
They will.
Yeah, I'm sure they will. So this is a heavy hitting episode, in my opinion. So you feel the same way, Terry?
Absolutely, yes.
So you take care of yourself, doctor. Once again, thank you so much.
Thank you.
Keep up the great work. And no matter what you do, you make sure you keep battling.
Thank you. The honor is all mine. Thanks for having me.
Notes and resources for this episode are available at abattlewithin.com/135. Connect with us at abattlewithin.com and on Facebook and Instagram at abattlewithin. If you would like to be featured on the podcast or know someone that you think should be, please reach out to us in the same places I mentioned a second ago. You can also leave a voice message on our recorder on the homepage of the website if that's your preference. Got any ideas for episode topics? Reach out with those ideas as well. If you like what you're hearing and want to support the program, the best way to do that is to rate and review the podcast on Apple Podcast, even if you don't use it to listen as your platform. It helps us to get into more ears. Links to do so are in the episode notes. Be sure to check out our Battle Within swag shop on the website at abattlewithin.com/swag. Until next time, for those healing, show yourselves some grace. For those who know someone healing, show them the same and give them a great deal of love. Keep battling, folks. Bye-bye.